Hello everyone, welcome back. So I've got a case scenario for you, and it is designed to help you apply concepts of fluid regulation, electrolyte imbalances, and nursing priorities using the provided sources. So we have here Miss Gertrude, who's a 78-year-old female with a history of congestive heart failure or CHF and hypertension. Her home medications include furosemide, otherwise known as Lasix, which is a loop diuretic and an ACE inhibitor or angiotensin converting enzyme inhibitor. Okay, so her medications basically make sense for her past medical history, right? So Miss Gertrude was brought to the emergency department by her daughter, and the daughter reports that her mother has had a stomach bug for the past 3 days with frequent vomiting and watery diarrhea. And she hasn't been able to tolerate any oral intake, including her home medications and water. And what's really troubling the daughter is that Miss Gertrude has increased confusion, lethargy, and she is severely disoriented as well, which is new for her. So now you complete your initial assessment, and your findings are her Miss Gertrude's blood pressure is 96/58, and she's sitting down. Her heart rate is 114, and it's thready. Her temperature is 37.2 degrees Celsius, and her respiratory rate is 22. You performed your physical exam, and what you noted was that her mucous membranes, they're very dry and cracked, and her tongue also is very dry and it's cracked, and it has deep grooves within it. And she has some skin tenting over her sternum as well. And neurologically, you noted that she was disoriented to time and place, but she still follows commands slowly. So I just want to dissect your initial assessment for a little bit here. So with the vital signs, right, so we see that the blood pressure is 96/58. Her heart rate is 114. So we know that this blood pressure is a little bit low, right, for a patient. But the question is also, why is the heart rate high? And is this something that we would normally see in a situation like this? Okay, so when the blood pressure is low. And the answer is yes, we would normally see a heart rate increase when a patient's blood pressure is low. That is the natural response of the body. That is actually a compensatory mechanism where the body is trying to increase the blood flow throughout the body in order to maintain cardiac output and also to maintain the blood pressure. So the heart rate being high, yes, it's telling me something, but it's something that I am expecting to see with the blood pressure being low. And the fact that the heart rate, you noted, was thready, that makes sense too in terms of all of my other physical findings where Miss Gertrude was not drinking well. She has dried mucous membranes. Her tongue is dried and cracked. She's got tenting over her sternum, right? So the pulse being thready is telling me there's not enough volume within Miss Gertrude's body. Now, I guess the question here is like, also for me, is like, why the temperature is 37.2? So when you go back to your anatomy and physiology, you would remember from your prior learnings that a patient who is over 65 years of age, their temperature would normally range from 35.8 to 36.9 degrees Celsius. And so my question would be then, why is this temperature up? Is Miss Gertrude septic? No, not really. But my next question is, does it fit the picture? And the answer is yes, it does fit the picture, right? And it is because with dehydration, there is an element of impaired blood circulation, like we see with the blood pressure being 96/58. And so the heart rate is also increased as well. And so there is less blood circulating to the surface of the skin. So it's making it harder for the internal heat to be released. And then we have also an increase in the respiratory rate, which is 22. And again, I'm asking myself, why is this respiratory rate 22? And the answer really is the one that makes sense, is because the body is trying to get more oxygen to the muscles and organs since the blood volume is lower. Also, if electrolytes, which we don't know yet what Miss Gertrude's blood work is like, but if her electrolytes like sodium and potassium are low, we know that those two are very important in muscle contraction, right? So Miss Gertrude's diaphragm must be impacted, and it's actually forcing her to work a little harder to breathe. Okay, so the vital signs are making sense with what is going on with Miss Gertrude in terms of her physical exam and what I was told when she first came in by the daughter, right? So what we were told. Okay, I hope this is making sense to you. So I guess our question here, let's do a little bit of a quick discussion, and I'll pause for a little bit so you guys can answer, on your end, okay, and think about it a little bit. But why is Miss Gertrude at a higher risk for fluid imbalances compared to a younger adult? So when we look at elderly patients, they are at a higher risk for dehydration. They only have about 46 to 52% of total body water versus a younger, healthier adult who has about 60%, right? And also, she may have a blunted physiological thirst mechanism, because that's also reduced when a patient gets older as well, okay? And then also she may have decreased renal reserves as well, which also is something that occurs in older patients as well, okay? So as a patient gets older, they are more susceptible to dehydration, okay? So this is why Miss Gertrude is at a higher risk for fluid imbalance, okay, compared to a younger person. Now, does Miss Gertrude exhibit fluid volume deficits, so hypovolemia or hypervolemia, based on her vital signs and physical exam? Yes, she does exhibit one of these, and it is fluid volume deficit. Okay, so hypovolemia. And this is actually supported by her being hypotensive, being tachycardic, having dry mucous membrane, skin tenting, confused, altered mental status. Okay, so I hope you guys can see that. Okay. So you did some blood work initially, and now the blood work is back, and we see that Miss Gertrude's sodium is 128, and the normal range is 135 to 145, right? So this is a low value, okay? And then we have potassium, which is 2.9. So the normal range is 3.5 to 5, so this is also low. And we have a BUN or BUN, which is 38, and the normal is 5 to 25. So this is high. And then a creatinine level of 1.1, and the normal range is 0.5 to 1.5. So this is normal. Okay? So a couple of things that we're worried about here are the sodium, the potassium, the fact that the BUN is elevated, and her creatinine is normal. You also notice on the ECG strip that there is some ST segment depression that's going on over here, And we also have a prominent U wave. Okay? So, with Miss Gertrude's lab work, what medical terms can we use for her sodium and her potassium levels? Yes, she's got hyponatremia for the sodium being low and hypokalemia for the potassium being high. Potassium being low. My bad, potassium being low. Okay? So, with that being said, the ECG strip that we saw earlier, that actually fits, right, with the hypokalemia. Okay? That makes sense. So, we will see that prominent U wave and ST segment depression. Okay? Now, what does a high BUN with a normal creatinine indicate in a patient with GI losses? It indicates pre-renal dehydration or hypovolemia. And so the ratio indicates it's more of a volume loss versus a primarily kidney loss or renal loss, okay? So when we look at the BUN creatinine ratio, when we do the calculation, 38 over 1.1, that's about 34. And anything greater than 20 tells me that this is a pre-renal dehydration. Okay, so it's strictly related to volume loss. All right, so I know then how to treat her. Okay. So as Miss Gertrude's blood pressure drops, which primary system activates to reabsorb sodium and water? Because the body doesn't like that, right? Like if the kidney senses that there is some volume loss, then it's going to start to kick in, right? It's going to start to kick in and start releasing some hormones. And so it's going to start the renin, angiotensin, aldosterone system, as well as activate ADH, so antidiuretic hormone, so that it can reabsorb sodium, reabsorb water, and hopefully then increase the blood pressure. So, like I said, the kidneys would then sense that the volume is low or the BP is low. The RAAS pathway, or the renin, angiotensin, aldosterone system pathway, will be activated. Renin will be released by the kidneys, and then it will be converted into angiotensin 1 and then angiotensin 2, which is a potent vasoconstrictor, which will hopefully then help to increase the blood pressure. Aldosterone would then be also released, which helps with increasing the sodium retention. And we know wherever sodium goes, water will follow. So that will also help to increase the Miss Gertrude's blood pressure and also the volume. At the same time, the antidiuretic hormone is released by the pituitary gland itself. And so with that, the antidiuretic hormone is strictly a water reabsorption pathway or hormone, okay? So the water will be reabsorbed, and again, that's another element that's going to help with increasing the patient's blood pressure, okay? So our body is fantastic, right? It does everything it can in order to maintain equilibrium. It hates being off balance, right? So the physician has now ordered an IV infusion of 0.9% normal saline. Is this isotonic, hypotonic, or hypertonic solution? And what is the ultimate goal of giving this specific fluid to Miss Gertrude in regards to her condition? Yeah, this is an isotonic solution, and the goal is rapid expansion of intravascular volume to correct the hypovolemia without causing drastic intracellular fluid shifts. Okay, so again, I mean, this is isotonic is pretty much the their solution is pretty similar to what our normal body composition is in terms of that particular electrolyte. So, and water. So the 0.9% normal saline shouldn't really cause much of an intracellular fluid shift. The other thing that we would have to be mindful here, though, is that she does have a history of CHF. So we would want to be monitoring her respiratory status to make sure that she doesn't go into CHF because we're giving her too much fluid. Okay? So, but this would be the normal or an acceptable solution to give to her at this point in order to increase her intravascular volume. Okay? So our nursing priorities and interventions are to infuse the 0.9% normal saline for volume expansion, and also I would say to replace her potassium. Okay, so we would replace the potassium based upon the electrolyte replacement protocol or policy that your hospital has, but it would be given as an IV piggyback. And for example, some of the concentration, so again, it depends on your hospital, but some of the concentration or the lowest concentration would be 10 milliequivalents in 100 ml. Okay, and then you would look up the policy to see how fast you would give it. But ultimately, we want to replace the potassium and also to give the normal saline. Okay, because we don't want the strain to be on the heart. Because the potassium is low as well. Okay, and we'll talk about sodium in a little bit. All right, so the provider ordered the IV piggyback for potassium chloride. What is the most critical safety rule or mandate regarding the administration of IV potassium? We never, ever, ever give IV push, IM, or sub-Q potassium. Okay, it must be properly diluted and administered via an infusion pump. Okay, and the patient has to be on a cardiac monitor for the most part. Okay, if we're giving high concentration, if you're giving like the 10 milliequivalents in 100 ml over like 4 hours or a longer period, which oftentimes you'll see on the general ward, then they may not need to have a cardiac monitor. But if we're giving higher concentrations, like 20 milliequivalents or 40 milliequivalents, then and maybe over an hour, then we need to put them on a cardiac monitor. Okay, but regardless, it has to be diluted properly and administered via an infusion pump, because it's very irritating to the peripheral veins. And if you're giving higher concentration of potassium, that needs to go through a central line. Okay. Now, why must the nurse monitor Miss Gertrude? Monitor her sodium correction very carefully, because giving the 0.9 normal saline will probably correct her sodium level as well. What is the risk, basically, of correcting hyponatremia too rapidly? Yeah, it's osmotic demyelination syndrome, okay? So we want to prevent permanent brainstem damage. If we give or correct sodium too quickly, it's going to cause a demyelination, right, of the neurons. And so we want to give it slowly, and the maximum is 8 to 10 milliequivalents per liter per day of a correction. Anything greater than that, it's too risky, okay? And then identify the priority treatment for her specific type of hyponatremia. which is hypovolemic, right? Hyponatremia. So what would be the priority treatment here? Yeah, fluid replacement, right? And so we want to treat the hypovolemia first and see if that will then correct the hyponatremia, right? So we want to give fluid replacement first, okay? All right, a few takeaways here. So age narrows the margins, right? So geriatric patients, they possess a decreased total body water, so they range around 46 to 52%, like I mentioned earlier. And they also have impaired compensatory mechanisms as well, okay? Versus someone who is younger and probably healthier, okay? When you have an elevated BUN paired with a normal creatinine and the ratio is greater than 20, this tells us that we strictly have a systemic volume loss issue, okay? We don't have a kidney failure issue, okay? So our treatment would be mainly focused on replacing the volume loss, okay? And the third thing that I really want to point out today is to never push your IV potassium, like I mentioned earlier. And we also want to correct the sodium slowly to prevent osmotic demyelination syndrome, which is permanent brain damage to the patient, right? So we want to make sure that we administer that sodium slowly and we correct it slowly, okay? And so these are risks that, that we need to make sure that we mitigate, okay? All right, so I hope you guys found this case study helpful, and I will bring some more to you guys, but I will see you guys later. Bye.